Hi, so my name is Ahmed, and I'm another one of the F1s at St. James's, and I'm going to talk about ENT. I only actually found out I was giving this lecture yesterday, so I quickly put together a few slides just to cover the main topics that you're meant to know in your core clinical conditions. So this is the kind of stuff that we're going to be covering briefly. And we're going to do this by going through a few cases that I thought would be most clinically relevant. First of all, quick wax. You need to know about this. Not very much you need to know. Do you know how we would treat wax? Earwax? Yeah, so olive oil drops or sodium bicarbonate, as well as syringing and microsuction. And tell your patients to throw away their cotton buds because they don't have. They just make it more difficult. Going on to cases. So the first case is a 35-year-old man who comes in complaining of a 3-day history of an itchy, painful ear. You examine his ear, and this is what you find. Can anyone describe the picture? What can you see? So this is what you typically see. I don't want to give away the diagnosis, but what you can see is inflammation and swelling of the ear canal, and that means that you can't actually see into the middle ear. So the diagnosis would be exactly otitis externa, and that's what you would see in the acute phase. Whereas if it was chronic, you can see here, you can see the tympanic membrane, but you find some excoriation, redness, and debris in the ear canal. So, in terms of the key features in management, the main symptoms that you get with otitis externa are pain and swelling in the acute phase, and like I mentioned, when it's chronic, you have the debris and discharge. There's a few predisposing factors, and that includes water, and that's why it's sometimes called swimmer's ear, as well as humidity. Trauma can sometimes precipitate it, and dry skin conditions such as eczema and psoriasis. In terms of causative organisms, it's usually bacterial, most commonly Pseudomonas. It can be caused by staph and streps as well, and sometimes fungal infections. Management is really quite simple: analgesia, ibuprofen and paracetamol, antibiotics. How would you give the antibiotics?
Topical drops.
Yeah, topical. And they usually contain steroids in them as well. And then if the symptoms persist, you can consider microsuction, and you should swab it just in case it's fungal infection, and then you can prescribe the appropriate antibiotics. Moving on, so a 5-year-old girl attends with the mother, obviously, and the mother tells you that she had a 24-hour history of a fever and pulling into her ear. What do you think the diagnosis is? Exactly. So in terms of key features, the main symptoms are pain. I mean, the main difference between otitis media and externa, apart from when you look in the ear, obviously, is the fever, because otitis media is more systemic. So pain, fever, and you can also have hearing loss, usually secondary to perforation. In terms of causative organisms, again, mainly it's bacterial. S. pneumoniae, Haemophilus, and Barnumella catarrhalis are usually the causative organisms, but it can also be viral. Treatment, quite similarly to otitis externa, is with analgesia. Now, the use of antibiotics is controversial. Most guidelines would suggest that you hold them off unless the symptoms persist for more than 3 days, in which case amoxicillin TDS for 5 days is the antibiotic of choice. You can also have a few complications with otitis media. They're not very common, but they do occur. The first is perforation of the tympanic membrane. This usually sort of spontaneously resolves within 4 weeks, but you should always ask the patient to come back within 6 weeks to make sure that it's healed. You can also get mastoiditis, which isn't very common, like I said, but you should be able to recognize it, because if you do see it, then that requires an urgent ENT referral. That's what it looks like. And then other complications include meningitis, intracranial abscesses, and facial palsy. So moving on, a 25-year-old man comes into A&E complaining of a 2-day history of feeling as if the room is spinning. So what symptom are we talking about here? Okay. Can anyone define vertigo? Exactly. So it's an abnormal perception of motion, and usually it's rotational, but not always. But usually it is rotational. So can you think of any differentials for vertigo? Yeah, that's one. Yeah. That's it. Any more?
Drunk for 2 days.
That's certainly the most common.
Dehydration?
Acoustic neuroma is what I'm looking for, as well as it's going to be one sign of stroke, but obviously you have to have other symptoms. So just, to be able to differentiate between these different causes of vertigo, you need to ask a few questions. One of the most important questions is how long does the vertigo last for, whether they've had a recent viral infection, any other symptoms such as nausea and vomiting, they're commonly associated with vertigo, as well as any auditory symptoms, tinnitus or hearing loss. So this is just a table looking at the different causes of vertigo and how to differentiate between them. So like I said, I think the most important question is the duration of vertigo. So in benign paroxysmal positional vertigo, it lasts for seconds, and there's no associated nausea and vomiting typically, and so you don't need to really know much about these maneuvers, just the fact that they're associated with BPPV. But if you do want to know more, there's loads of videos on YouTube. So the Dix-Hallpike maneuver is diagnostic, and the Epley's maneuver is curative for BPPV. In Meniere's disease, the vertigo typically lasts for hours, and there's associated nausea, vomiting, and tinnitus. That's wrong. None of that stuff is supposed to be there. And treatment is with beta-histine and low-salt diet. Labyrinthitis, the vertigo can last for days. Typically there's only nausea and vomiting. Sometimes you have tinnitus and hearing loss. In about 50%, they're associated with a recent upper respiratory tract infection. And typically you have gradual recovery, and treatment is with prochlorperazine for 2 weeks, really just for the nausea. And finally, acoustic neuroma, in which the duration of the vertigo can vary, and you have all the symptoms really, and you can only diagnose it with an MRI, and treatment includes radiotherapy and surgery.
Do you mean gradual recovery as in like gradual recovery of the vertigo, or gradual recovery of the condition?
Of the condition, yeah. So, in terms of disorders of hearing, I've divided them into the part of the ear where it could go wrong. So, initially in the ear canal, and mainly we spoke about otitis externa, not typically associated with hearing loss, but sometimes it can be. Wax, obviously, as well as foreign bodies. In the middle ear, it can be because of perforation, secondary to otitis media, and then you have cholesteatoma, which we'll go on to talk about. In the inner ear, the main causes are congenital hearing loss, which can be syndromic or non-syndromic. It can be sort of acquired in utero because of infections or drugs, and it can also be acquired at birth because of hypoxia. After that, you have presbycusis, which is the deterioration of high-frequency hearing with age, associated with age, and it usually starts around the age of 18 to 20. And then finally, sudden sensory neural hearing loss, which is exactly what it says on the tin, basically. And there's good spontaneous recovery with that. High-dose steroids can help, but they have to be administered within the first 10 days of the onset of symptoms. Okay, so a little bit about cholesteatoma. So this is a condition that's secondary to inward migration of skin from the ear canal, and it can erode into the bone. and this means that patients present with painless discharge and hearing loss. There's a few complications, including complete deafness, meningitis, intracranial abscesses, and facial palsy. The treatment is normally surgical, and this is what you typically see. So dull tympanic membrane with crusting around the uppermost part of the ear, that's also referred to as the attic. So moving on from the ear, so this is a 25-year-old man who attends A&E with persistent nosebleed lasting for over 30 minutes, and there's no history of trauma. How would you manage this patient? Any ideas? Okay, so you start off with, whenever you're asked how do you manage this, always ABC. You need to investigate, including doing a full blood count, clotting, group and save, and you can use some first aid measures. The thing that, the most important measure is probably nasal packing, which you can use nasal tampons to stop the bleeding, and if that fails, then you can refer to ENT for cautery. And really, after you use the nasal tampons, you should try to think about why is this person having the bleeding in the first place. So you can divide sort of epistaxis into local causes and systemic causes. In terms of local, it can be inflammatory or trauma or infection. In terms of systemic causes, then the main things to think about are bleeding disorders, hypertension, or any medications that they're on. So it's always important to check if they're on any anticoagulants. Moving on. So this is the case of a 15-year-old boy who attends complaining of a 2-day history of a runny nose, sneezing, and itchy eyes. Yeah, allergic rhinitis. So in terms of allergic rhinitis, the management is mainly to avoid the allergen, and this can either be sort of seasonal allergic rhinitis such as hay fever, or it can be what's called perennial allergic rhinitis, and with symptoms occurring throughout the year, and the allergen being anything from house dust mites to feathered pillows, as well as pets. So the main thing is to find out what the allergen is and make sure that patients avoid it. You can use oral antihistamines such as cetirizine, as well as eye drops such as sodium chromoglycate, and leukotriene receptor antagonists are also helpful in this case. And if you're not sure about the allergen or the diagnosis, then a RAS test is indicated. Does everyone know what that is? So it's just a test where you apply different allergens to a patient's skin, and you find out what they're allergic to by monitoring the reaction to those allergens. So this is a case of a 25-year-old man with a 2-week history of fevers, facial pain, and tenderness and nasal congestion. Yeah, exactly. So sinusitis can be divided into acute, recurrent acute, and chronic. Acute sinusitis is when there's inflammation of one or more nasal sinuses lasting for 2 weeks. It usually resolves spontaneously with no complications, and is treated with analgesia, antibiotics, and decongestants. Recurrent acute sinusitis is when you have more than 4 episodes of sinusitis in 1 year, and chronic, again, is when you have sinusitis lasting for over 8 weeks, and usually you have metaplasia of the nasal mucosa. It's treated the same as acute sinusitis, except you can also use steroids as well as surgery. So complications, we should know about these because they're fairly serious. So you can have in the eyes, you can have periorbital cellulitis, subperiosteal abscess, ophthalmoplegia, intraorbital abscess, and eventually blindness. In the brain, you can have meningitis, extra and subdural abscesses, and intracranial abscess. So now we're moving on to the throat. Our final case is a 20-year-old patient complaining of a sore throat. So can you think of any differential diagnoses, acute and chronic? Yeah, so tonsillitis, pharyngitis, all of that stuff. And chronic, any chronic causes? Yeah, EBV would be sort of recurrent, but I mean, a sore throat for a long period of time. So you're quite right. In the acute, you have viral causes, bacterial beta hemolytic strip, as well as candidiasis, and chronic. You can have poor inhaler technique, gastroesophageal reflux, and smoking. So, what further questions would you want to ask this patient with the sore throat?
With any medication?
Yep, any response to any over-the-counter medication?
He has any recent antibiotics?
Recent antibiotics?
Have they been systemically unwell? Is it kind of fever or?
Exactly. So you want to find out duration of symptoms, any associated fever, cough, any coryzal symptoms, and any over-the-counter medication. So the patient says he's had the symptoms for 2 days, has had a fever, but no cough or coryzal symptoms. And when you look in the mouth, this is what you see. So you can see clearly inflamed tonsils with some exudate. Now, so this patient has tonsillitis. Does anyone know of any criteria that we use to determine whether patients will benefit from antibiotics in tonsillitis? Exactly. Anyone know what those criteria are? Yes, exactly. So, any 3 or more of these 4 criteria means that the patient is likely to have bacterial cause of tonsillitis, and they benefit from some antibiotics. And the antibiotic of choice is penicillin B, 500 milligrams QDS for 10 days. Yeah, and how would you treat it?
Drain it.
Exactly, so you have to consider admitting the patient for aspiration or drainage.
Sorry, was it not?
It's peritonsillar abscess, Quincy. That's all? Leave it up there.